Hello, everyone, and thank you for tuning into the NAACP TV forum here in the city of Brockton. We have an awesome program this evening focusing on prostate health. Tonight, we have several, I'm going to say, world-renowned physicians that have joined us this evening. We have survivors that want to talk about how they were able to deal with the prostate cancer in their life. But just as a housekeeping matter, tonight I was supposed to be joined with my co-host, Leona Martin. Leona is not feeling well, and unfortunately, she won't be with us this evening, but we wish her well. Tonight, I want to acknowledge the Brockton State House delegation, inclusive of Senator Michael Brady, Representative Jerry Cassidy, State Representative Rita Mendez, and State Representative Michelle Duaz. They are champions of the prostate cancer educational program for high-risk men, and with the priority focusing on African-American, Hispanic, and Latino individuals. I invite State Representative Cassidy or Mendez to provide some welcoming remarks.
Thank you, everybody, for being here tonight. This is so important. So I'm Rita Mendez, the new elected representative here in the city of Brockton, and I'm just honored to be part of this project. And the fact that we know that Black men are more likely to die from prostate cancer causes us to ask the question why. So that is why this program about the prostate cancer equity program in Massachusetts is so important, is so crucial, and is so vital, because then that way we need to spread the message and bring that awareness about this program. So I'm happy to announce that we were able to pass the budget in the House that leaves $1.2 million for this project. So we'll continue to pray, because now it goes to the Senate until it becomes final. But that shows the dedication of the entire Massachusetts delegation, that we take this very seriously, that this is something that needs to be spoken and talked about, and so that we can end this stigma. We can ask the questions why Black, Brown, Latino men are more likely to die from this disease, and find ways to help save lives. And I'm just so honored to be here tonight with so many amazing people that will be talking about more. Thank you so much for the opportunity. Thank you for being here.
Thank you, Representative Mendez. I'm looking to see if State Representative Cassidy is here for remarks. I don't see the name labeled, so I'm going to keep moving on with the program. So just to piggyback off of what Representative Mendez said, just looking at the white papers, I just want to quote, it says that prostate cancer disproportionately affects African-American males, which incidence rates of 1.6 times that of non-African-American males. We're here today because the statistics says where there is early detection, it can prevent deaths and metastatic spread. With that said, why don't we go to a survivor well known to the city of Brockton? I'd like to introduce to you Darren Duarte, our Director of Communications for the Brockton Police Department. Darren, good evening.
Good evening, Tony, and thank you for having me. And I've got to say, I owe a debt of gratitude to the Brockton chapter of the NAACP and AdMeTech Foundation. I was going to a lot of these events when we used to have them in person at different areas around the city. But often I would hear the remarks from the physicians, urologists, and from survivors, and I didn't take any action. I didn't take any action at all. And then one day, after going again, I said, these folks are not just doing this for their health. Let me just go and get myself checked out. And I'm glad I did. Because eventually what we found was I not only had prostate cancer, but I had an aggressive form. So aggressive that the doctor said we need to move fast, because they thought, and he thought rightly, that the cancer was confined to the organ, but it was only a matter of time before it went outside the organ and went into my bloodstream. And that could have caused some serious problems, obviously. So I owe AdMeTech, NAACP for always having these kind of events. And I want to tell folks who are listening right now, if you haven't gone, to get your PSA test or get checked out, please do. It's so vital and so vitally important. And not everyone has prostate cancer, but not everyone has it, has an aggressive form. But you're not going to know unless you go see your doctor, unless you go get tested. And even then, you still may not know. In my case, I did go to the doctor, and it took a few times going when I had to be my own advocate, because for some reason I sensed there could be something wrong when I looked at the numbers. And so I talked to my urologist, and we decided, from my also pushing, that maybe that we need to go further than just doing urine tests and so forth. So we had a biopsy, and that biopsy told me and told him how serious my cancer was. So this was 2018. I had surgery in 2018 to remove the prostate, get tested. I was getting tested every 6 months. Now I get tested every year. And still so far, no sign of the disease. So if I could say anything to the people who are watching, people who are listening, please take note and take heed, because you never know unless you go and find out if in fact you can save your life in time if you get detected early. Thank you.
Darren, just a quick question. One of the things that we've found out in this work is that, folks like yourself that bring credibility to force us at that edge to get in that doctor's office to make sure we need to complete whatever diagnostics we need. Just tell us, what can we do? And I'm black man to black man, because we are pretty tough. We're saying we're not going to go get checked out. So how do you encourage your brothers to get over that hump?
I know a lot of us, and me included, I didn't want to go. Yes. And I wasn't so much fearful of what I'd find. In my case, it was lackadaisical. I'm thinking, this couldn't happen to me. They're not talking about me. And when I would go to these forums, I would hear everything, but you think, well, that's not going to happen to me. But boy, you don't know if it's going to happen to you or not. And it did happen to me. And luckily, through the grace of God and through the grace of the medical community, they saved my life. Because if I kept going on, that cancer, as these doctors will tell you, could have gone metastatic. Who knows? I may or may not have been here now. My surgeon even said within 5 years, if I had not done what we did, there's a good chance I wouldn't be here. So I would tell people, if you think, they're talking about somebody else or they're talking about other people, they're talking about all of us when they say we need to get checked out. It's all of us, particularly us black men, but everyone on this earth should get checked if you can, because it is one of those diseases that if you catch it in time, you can be treated in time and you can save your life. And I think a lot of folks who end up dying end up finding out way too late.
Way too late. Wow. Way too late. So we are actually doing very good on timing. So I'm going to have to use some personal privileges here. So Dr. Stern, when he says way too late, what does that mean?
Unfortunately, fortunately, Darren came to our events and decided to talk to some of us and decided to get tested. Unfortunately, as he pointed out, he had very aggressive form of prostate cancer. And unfortunately, Black men tend to have more aggressive form of prostate cancer. So if you miss detection of cancer in early stages when it is still confined to the prostate and disease escapes to other organs, as Darren was at risk of this kind of metastatic expansion, the difference in survival is very striking. And I will show in my presentation that with early detection of prostate cancer, when it is confined to the organ, to the prostate, survival is actually 100% in 5 years. When there is metastatic spread, particularly to distant organs, survival is 28% in 5 years. what it means that out of 100 men who were diagnosed with advanced metastatic spread, only 28% of men will be alive in 5 years. It means that we lost 72 out of 28 men. And remember, the difference, early detection, everyone survives. Late diagnosis, we lose 72% of men in 5 years.
Wow. It's a serious disease, and we can do something about it. And
Absolutely.
Dr. Stern, yeah, one of the things, I mean, you have been, I remember when we first met, you, myself, and Steve Bernard, you've been so awesome in these programs and bringing this to our community's attention. So, I mean, we really salute you as a life-saving hero. And so we thank you for that.
Thank you so much.
Thanks, Doc.
But it's important, you know, I'm going to tell you, in my community, word of mouth means a whole lot. And that is one of the reasons why I was asking Darren, you know, how do you go to the brothers and say, you need to go get checked out, you're feeling something's wrong, and you just need to, you know, it's not to demasculate, you need to take that strength and push you over into urgent care or to your PCP to make sure you get checked out. And word of mouth is so important. This is why I am so excited that the Roberts family is here to give us their testimony, to give us their story with respect to prostate cancer, testimony that we all need to hear. Deborah, are you going to do it?
Oh, yes. Hello, everyone. First of all, thank you, AdMeTech, and thank you, NAACP Brockton, for allowing us to be here tonight to talk about our story. My name is Deborah Roberts, and I'm the chair of the select board in the town of Stoughton. One of my passions and focal points is healthcare, closing the healthcare disparity gap. And when I look at statistics of our people of color, our Black males, all people too, you never think it's going to hit you personally. And it did hit. We talk about the statistics that 1 in 7 males will be diagnosed with prostate cancer. We talk about those males of African descent are 2.5 times more likely to die of prostate cancer. My husband, Charles, he'll talk right after me. Well, he was diagnosed. He was fortunate enough to go to the doctor early for early diagnosis. But I'm here to attest to you that women and family members are impacted when your male is diagnosed with prostate cancer. Now, I'm not going to sugarcoat this. No sugarcoating here. This is hard. It's hard work. It's hard on the family. Sometimes late at night, we're crying together. We're trying to pool our strength to help Charles move forward. And he has. Charles is a survivor. And that is fortunate. And early detection is what helped save him. So me as a public servant of the town of Stoughton, I pledge to continue this good work, to encourage everyone to go see your doctor, go get checked out. And I'm hoping that all select people and all counselors spread the word to their constituents. And once again, Black, all males, or 1 in 7, will be diagnosed with prostate cancer. African American descent are 2 times more likely to die of prostate cancer. Now, all of these are facts, and facts are friendly. Please go get checked out. Charles.
Good evening. My name is Charles Roberts. I am a retired Stoughton police officer. Like my wife was saying, I was diagnosed with prostate cancer, and luckily I was diagnosed early in stage 2. Back in November of 2020, during a regular physical. My PSA, which is a test that they give you when you have your blood work done, was way up at 13.7. And they start watching you when it's like at level 4. They start to try to do something about it. But mine was really high at that point. The time before that, it was just below 4. So I went and saw a urologist in December of 2020, for the biopsy. And that time it was confirmed. And I had an area on the right side of my prostate. And within that area on the right side of my prostate, they had one section inside the cancer area that was aggressive. So they were going to treat it, the whole prostate area, as the cancer being very aggressive. Also back in December of 2020, I started taking some natural herbs that I received from my daughter and my brother-in-law, a CBD solution, which was going to help. At this time, my prostate was enlarged, and that solution helped reduce my prostate back down to a normal level within a 30-day period. In January of 2021, I started taking a pill form of chemo, which I took from January to like the middle of June of 2021. And shortly after that, in March of 2021, they started giving me a hormone, which was going to reduce my testosterone, which is what feeds the prostate cancer. So I took that. They told me I was going to have to take a shot every 4 months for 2 years, which I just finished it in August of 2022. And then I started radiation treatments from early June till late July, which was 5 days a week for 44 sessions. Like I said, I just finished my 2-year process with the hormone treatment in August of 2022, and I'm on the recovery end of it now. I'm not taking any more treatment, but I'm still recovering from the treatment that I received. The treatment that you receive, everybody's situation is different, and they try to make your treatment for you, for whatever situation you're in with your prostate. Also, I go in every 6 months to have them check to see where I'm at, and so far I got negative cancer on the prostate, and I still have my prostate. So I'm still on the recovery stage. It'll probably be June. The recovery's real slow. I'm getting a little bit better every day in terms of the energy level. And that's one thing that all this does, is it drains everything from you. If you're a person that normally has a lot of energy and does a lot of physical activity, all of a sudden that's gone. I'm trying to get back to that level now. So, and what I can say about the prostate is, like, when you go, I get a normal physical every year, and that's how it was detected. And as soon as I found out about it, I knew it was going to be a lot of work when they explained to me what I'd have to go through, but I was willing to do it because I wanted to take care of the problem. And all I can say is for men, I don't know what the problem is. I don't know if it's that they lack the healthcare insurance, or they just don't want to be bothered. But I think it's guys. I've got a few family members that have died from this, and I think it's a good idea. And men, get yourselves checked out, and if you got a problem, have it taken care of. And like I said, I'm here to contribute and give anything I can, do anything I can to help out and to promote that. Thank you.
Well, thank you for that testimony, and thank you for that important information. I just want to bounce, between, again, I'm taking some personal privileges because I know people have questions. When I listen to your wife, she speaks with authority.
Yes.
And I'm kind of wondering, I know you said that you found out, through your regular physical, your regular visits, how much of her influence took you to that next level?
Well, I'll tell you this, is that when I found out that, when it was confirmed, I took some time to try to figure out how I was going to tell her this, because I knew how she was going to react. And I tried to be as calm as I was, because even though prostate's the kind of thing that if you get it early, that, I mean, they can take care of it, the chances of survival are like 99.9%. But when they tell you something like the way the doctors explain it, the way the doctors tell you that, I mean, it's like devastating. And I was like, whoa, you know, in my mind, I said, I don't know how I'm going to, because I know how Deborah can be and my kids can be. Yeah. So I said, well, look, I'm just going to come out and tell her, you know, and that I plan on doing something about it. I wasn't going to sit there and say, well, I'm going to think about it. You know, I'm going to do what I need to do. So whatever program they brought to me, that's what I was going to follow. And luckily it worked out for me. And like I said, the only thing I've got going now is that I'm just trying to recover from the treatment.
Right.
Yep.
But let me add this to the story. I'm the one in the family that chooses the doctors and have my schedule. Well, did you go to the doctor? You're supposed to have your doctor's visit on XYZ date, and we have it all scheduled out, and I track it. And that's the same thing with dentists too, because it's your total health. Going to the dentist, going to your physician, your primary care physician, your medical provider to get checked out. And to have a program like AdMeTech's equity program. I mean, Chuck told me before, this is years ago, he's always gone to have his physical, but he said when he was introduced to AdMeTech, he says, oh my God, what a blessing. If I had known before, maybe there was some other alternative. You know, it's just a wonderful thing. But I would like our daughter, Erin, to share from her perspective, because, you know, daddy's little girl.
Erin, we welcome your comments.
Hi, everyone. How's everyone doing?
Good.
So my name is Erin Roberts. I am the CEO of Effulgence, which is a CBD and dietary supplement company. So how I came into play with this was that during the waiting period that my father had, you know, going through the process, is when I came in and I took action on giving him alternative medicine. So I am about the preventative stages, taking care of your body, eating right, you know, detoxing, things like that. But I've also, through this journey, I've also became a part of the AdMeTech team. And what I love about AdMeTech and what they provide with our prostate cancer equity program is that when you, for qualified patients, this is an expedited process. Okay, we go start to finish with our patients, before and after, when we go through the screening, the biopsy, and the treatments. So as you see my father here, you know, he has to, you know, kind of go through this alone without his doctors, just, you know, checking in here and there every once in a while. So we're the family is the ones that are really trying to help monitor this. But, you know, like my mother and father said, like my mother said, if we would have known about this program before, he would have had a whole different experience with this. So what this does is that we have a whole team of collaborating organizations with hospitals such as Mass General, Brigham and Women's, other organizations such as UMass. So, and what they do is that, you know, they address the unacceptable breakdowns of the process that you're going through. You know, if you, there is a stigma that just because you have the doctor that you have and the opinion that they give you, that's the route that you should go. And most of the time that's not, you know, the correct way that you should go. A second opinion you should always take. So what AdMeTech also provides is second opinion. And most of the time, you know, with the process that we give through talking with the patients, what they're going through, we understand that you may actually have additional major health issues, that you're in an angry state of mind. So we are not here to ruffle any feathers. We are here to go through the process with you. And that's the difference that I believe that AdMeTech spreads when we're trying to spread awareness about prostate cancer, and what our prostate cancer equity program provides for men, especially Black and brown men 40 plus years old. So again, I do advocate for eating healthy, preventative action, but also to always, always, always refer to your doctors. They have the knowledge, they have the tools, they have all the resources that you need to get yourself healthy. So, and that's where I stand, even with the philosophy of my company. So, and it was very hard. I would just like to say to add on, with my mother and my father, it was very hard. I even had to take immediate action, sometimes getting angry, not getting angry, being sad that I had to see my father going through this. And him being a retired Stoughton police officer, he's very active. He was a sniper trainer. He was a mentor for a lot of people for many years. So him going from, being so active and going to the gym all the time, having a routine, and then he had to, retract back. There was definitely a change for the family, but we are moving forward, and we are glad that we have AdMeTech in our lives now. And so please, if you have any questions, please always refer to the website, www.admetech.org. And also you can visit me by any chance. I'm always open, and I would like to turn this back over to Tony.
Aaron, I have to ask you this question. I want you to answer it like it's just you and I talking. They're not a part of this conversation. So your dad gets diagnosed with prostate cancer. For the sons and daughters, the nieces and nephews that are listening to this, that may listen to this, what do you say to them on how to handle the news the first time?
My advice when you hear the news the first time, I would say stay in a calm state, because it's not about you. It's about the person that's actually going through it. So if you can stay calm and be that person's backbone, and be their guidance and their resource when they're getting flustered and they don't know what to do, that's the best thing that you can be for that person. You're not going to know all the answers. You're going to feel embarrassed, sad, guilty, but it's a process that you're going through together, and you're going to make it through once it's detected, or if it's detected early.
Deborah, same question for you. What do you say to the partners out there? Hear the news for the first time. I know of some that, their first reaction would be, I don't want to hear that. No, this can't be happening. What do you say to partners and spouses that first time?
That first time, you say to them, what can I do to help you? I love you, I support you, and I will be here for you, and mean that.
Yeah.
Because you're going to hear some discouraging information as they tell you about the prostate and cancer. But you just have to give them that assurance, and that's the true meaning of love. Love is patient, and listen to them. And like Aaron said, it's not about you, it's about them. How can you help them? And you also need a support group. And we talked about that a little bit earlier, like everyone on this call, they said how they know people that are affiliated with AdMeTech. Well, that's a support group. You need a support group because males should and would like to talk to other males that are going through this or that have gone through this. They need that hope, that support that will help them to move forward every day, move forward in this journey.
Can I please make a comment?
Sure.
Thank you so much. Charles pointed out that he had to go through a long course of hormonal treatment that essentially had him drained of energy. And it is a tough treatment to go through. It's a life-saving treatment, but it's tough treatment to go through. And what is important for everyone to know, if we cannot keep our heads in the sand. The earlier we are able to diagnose prostate cancer, the less likely it is that men will need hormonal treatment. The more likely it is the treatment will be minimally invasive, or it will not require systemic treatment like hormones that that cause this long period of treatment and considerable period of recovery.
Wow. Thank you, Dr. Stern, for that. Thank you for that very important information. Going back to the Roberts family, we salute you all. We hug you from a distance. Awesome work with Brother Charles. And you all obviously have a well-educated, prepared daughter. So I'm sure that this equity is no longer going to be too much of a question as we move forward. Great job, Erin. Thank you, thank you, thank you.
Thank you. Thank you, everyone.
Want to move on to introduce Dr. Sean Wason, who's a urologist and a prostate cancer expert at Bethesda Deaconess Medical Center, the Milton Center for Specialty Care, and Harvard Medical School. Doctor, welcome this evening.
Thank you so much, everyone. I appreciate the invite, especially the AdMeTech and the NAACP. I just want to echo Faye's comments, Dr. Stern's comments. There was a recent study that came out, the PROTECT trial, where they looked at, what is the difference between men who undergo radiation and surgery, and they looked at men after 15 years. And if you had, upfront treatment, there was less risk of metastatic disease. And if you don't have metastatic disease, if you don't get metastatic disease, then, you don't really need hormonal therapy. And I think it's something that when someone's choosing radiation, we don't talk, too much about it, but it really can, affect quality of life. So, and I love this format here. It's fantastic, where we have, patients sharing with each other. The American Urologic Association, the AUA, really picked up on this, and how powerful, it is to hear, patients hear from other patients. And we just had our annual conference in Chicago, and now there's new sessions where we invite patients to come speak to urologists. We want to hear from you, how did this diagnosis make you feel? And it reinforces to the urologists and the trainees that, patients are, the lifeblood, and what you're doing, learning is really making a difference in everyone's life. So I appreciate the opportunity to talk, and I was just going to take the next 10 minutes or so, just kind of go over some of the advances in screening, how we make the diagnosis, and some of the treatment for prostate cancer. So really no disclosures, but like the Roberts family, prostate cancer, has affected my family. This is my grandpa Ernest, grew up in Barbados, and he ended up developing, being diagnosed with metastatic prostate cancer. At the time, there really wasn't the tools that we had available, for screening, and there really is a cut point between prostate cancer that's still within the prostate and that has spread. And we really want to find prostate cancer when it's localized to the prostate. So, in terms of screening, what are the goals of screening? Who do we screen? How do we make the diagnosis? How are we using some of the new imaging modalities and other tests like biomarkers to make the diagnosis? And then what are the treatment options for patients with localized disease? Just as sort of a brief overview, the prostate's a small little gland. Usually it's about 30 grams, about the size of a walnut, and it sits tucked in between the rectum, the urethra, and the bladder. It's part of the urethral channel, and as men age, it tends to grow. It can compress the urethral channel and cause a lot of urinary symptoms. Just because you have urinary symptoms doesn't mean that your prostate is affected with prostate cancer. The other sort of issue that the prostate can have is something called BPH, so benign prostatic hyperplasia, which is an enlargement. It's a reproductive organ. It contributes to semen, and like it's been mentioned, it affects men's number one cancer in men. 1 in 8 men will be diagnosed with prostate cancer in their lifetime. The longer you live, the more likely you'll be diagnosed with prostate cancer. But I think that there's different flavors of prostate cancer, as you will. And we have low-grade, intermediate, and high-grade cancers. And really, we want to focus on the intermediate and high-grade prostate cancers. These are the lethal cancers that will affect, quality of life and health. They're lumped in here. There's also low-grade cancers, and these are non-life-threatening cancers. And it's important to know that a lot of men are diagnosed with non-life-threatening cancers, and we really need to differentiate the two. And the goal of prostate cancer screening is to decrease unneeded biopsies and treatment. When you hear a lot of the studies saying, oh, PSA testing is no good, I think the reason why is because they've lumped together men into sort of this one particular group. And we realize that over the last couple of decades, we've been over-treating a lot of men that really didn't need treatment for prostate cancer. And now we just need to focus on the intermediate and high-grade cancers. So the American Urologic Association, they've come up with a guideline. Every couple of years, this is updated. And really the goal is early detection. So screening means that we want to find disease at an early stage before it becomes symptomatic. You're not going to have symptoms. You just need to, go to your primary care doctor, get a PSA, get a digital rectal exam. If you're under the age of 40, you really don't need a PSA. You can wait till later on in life. I would say, if you're about 45, you should be, thinking about getting your PSA. And I would encourage men to at least get one PSA at the age of 45. If it's low, you can space that out. The men that get the most benefit from screening, however, are in between the ages of 55 and 69. And these are the men that we would encourage to get screened for prostate cancer. If you're over the age of 70, 75 in poor health, then screening may not make the most sense, but you have a lot of, physically fit 70-year-olds who would benefit from PSA screening. PSA, prostate-specific antigen, it's just a blood test. I always combine it with a digital rectal exam. Ideally this should be done on an annual basis. I had this great guy today came in and I only had 2 PSAs on file, but he literally came in with an Excel sheet looking at his PSA trend over the last almost 20 years. And obviously he was an engineer, but you could tell that he knew exactly what his PSA was and over time. And I would say that it was marginally elevated, but I knew he was, very well educated. And, we actually opted to kind of continue to watch his PSA and not act on it. In order to make the diagnosis of prostate cancer, you do have to do a biopsy. PSA is a protein in semen that liquefies the ejaculate. It circulates in the blood. So if you have a prostate, you will have some PSA. It's only made by the prostate, which is good, but PSA levels can be elevated for different reasons. And so if you didn't have a prostate, your prostate is removed, your PSA should go down to 0. And so that's a good way to tell, has disease come back? We check a PSA. And so this is really one of the, the first biomarkers that we have, meaning that, it's a blood test. We've used it in kind of screening. We use it to make the diagnosis. And then after treatment, we follow the PSA. And it's very important after treatment to know what your PSA levels, how do they nadir, meaning, how low do they go after radiation and after surgery, or my PSA is undetectable. And then we use it in advanced disease, and we use it to determine the efficacy of treatments in the metastatic phase. So we don't do mass screenings anymore. You really need to have a one-on-one conversation with your primary care provider. If they haven't asked you about it, I think that, it's very reasonable to ask, what is my PSA? Is screening right for me based on my overall health? Patients that are, we consider high risk, patients that have like first degree relative, a father, a brother diagnosed with prostate cancer, Black men, African-American men, men of color. If you have, multiple malignancies in the family, so these are, breast cancers, ovarian cancers, or BRCA1 mutation, very high risk men need to be screened. The primary care doctors will ultimately determine, who gets screened, and then urologists tend to determine, who gets biopsied. if someone comes into my office for unrelated reasons, I will sort of ask about a PSA, and if they haven't had one, then we'll offer that in our office. And so the PSA, it's on a range, and so it tends to go up as you age. If the PSA is under 1, you don't really have to worry about it. You can space out those intervals. If it's that 1 to 3, and then you have a normal digital rectal exam, you can repeat testing every 1 to 2 years. We probably want to see, all men with a PSA over 3. If you have a suspicious digital rectal exam, and then that way we can counsel you on different things that we can do. And I would say, I have a lot of men come to see me for an elevated PSA. The first thing that we're doing nowadays is we're not offering biopsy immediately, but we're setting you up for an MRI of the prostate. And I would say that this has, been a game changer over the last, 5 to 10 years. It used to be that insurance didn't really, pay for MRIs up front. Now, someone comes in, they have an elevated PSA, I'm getting an MRI. I want to know, do you have one of these suspicious lesions, or are you someone who we're less concerned about? Other things that we can do, we can get an abdominal ultrasound. This gives us the anatomy of the prostate right away in the office. And we want to know the size, because if the prostate is very large, then we would expect the PSA to be a little elevated. And so we're probably less concerned about you. Different ways that we can do a biopsy. One is through the rectum, the historical approach, the transrectal approach, but now there's also the transperineal approach. So the area between the anus and the scrotum, and we go through the skin, and interestingly, there's less risk of infectious complications, virtually 0. And this is just one of the ways that we do a biopsy. We were fortunate to be one of the kind of early sites to do research on this particular high resolution ultrasound probe. It's really picked up in England, and I think the timing was a little off for the US because MRI was coming out around the same time, but there's some centers that have a very nice ultrasound picture to look at different lesions. The nice thing about this type of ultrasound gives you like a really high def view of the prostate. There's a scoring system, and it's actually a lot cheaper than MRI. If we decide that we're going to do a biopsy, we're taking typically 12 cores. So man comes in, elevated PSA, we get a MRI. The MRI is going to tell us any suspicious lesions. If there are suspicious lesions, then we will do one of these fusion biopsies. If they don't have a suspicious lesion, then we would typically do the standard template, 12 cores in total and 6 on either side. And that's really going to tell us, do you have prostate cancer or not? If you do, is it one of these low-grade cancers or one of the more concerning prostate cancers? And then each sliver, how much cancer is there? And they give it a group, a Gleason score. So I think it's very important that men, ask about how many cores were positive, what is my Gleason score? Because that's really going to dictate the type of treatment that men get. Oftentimes we'll see, a small focus of a Gleason 6 cancer, less than 5%. That's someone who we don't want to treat with surgery or radiation. So I talked about multiparametric MRI. It's got to be a 3 Tesla magnet. It has to be done with IV contrast, and not all centers are set up for the MRI. So some of the questions are, is this radiologist experience in reading prostate MRI? And it really takes this type of radiologist to really be focused on prostate cancer. So these are some of the, the major academic centers in around the area. We're typically doing this pre-biopsy. We look for these suspicious lesions, and then we can also tell, is there any disease that wants to come out of the prostate? Are the seminal vesicles involved? Are the lymph nodes involved? Are the bones involved? So it gives us a lot of information locally to decide maybe how we're going to do the biopsy and what type of prostate cancer you may have. Another question, if you have an MRI in front of you, focus in on the PIRADS lesion. So it'll say there's a PIRADS 4 lesion. This is the size. So 4 and 5s are really the numbers that we need to be concerned about. Those are the ones that need to be biopsied. And then now we can take the MRI, we can put it on our ultrasound, and now we can direct the needle exactly where the prostate cancer is going to be. We call this an MRI ultrasound fusion biopsy. It does require some different technology and software. but this is the standard nowadays. We know prostate cancer is a spectrum of disease, and there's very low, intermediate, high, and very high risk disease. And so, there's a, sort of a complex algorithm as to what kind of testing you need after the biopsy has been done and if it comes back positive. I'm using biomarkers routinely now in my practice, and there's a variety of them out there. And the way I use this, if someone has a negative MRI, it says, oh, it looks like there's no suspicious lesions, but someone's really concerned or the PSA is up, we can get one of these biomarkers that gives them almost like a genetic risk of having, more aggressive prostate cancer. And so some of these are just sort of urine, but I think they're helpful in sort of those gray areas where, we're not sure if we need a biopsy right away. So this is just one Oncotype DX. This is also for someone who has biopsy proven disease, but they have a very small focus of Gleason 3. We can actually send that prostate cancer to the lab, and then they can test that to see if that is harboring any concerning features. Using a lot of biomarkers, and there's more and more sort of available. Let's say we have prostate cancer that diagnosed. We want to know, has it spread anywhere else? Historically, we would get a CT scan, a CAT scan, and a bone scan. This is just a picture of unfortunate some prostate cancer that spread to the bones. Nowadays, there is sort of a more sensitive test, PSMA, prostate membrane specific antigen. And now we can inject a radio tracer into the bloodstream, and then this will latch on to prostate cancer, and it will tell us, is there prostate cancer outside of the prostate? Because the treatment is a little bit different for when it's localized versus outside. If it is localized, you have surgery, you have radiation, there's sort of different types of radiation, or, we may not treat you right away. So if you have one of these low risk disease, active surveillance is something that we would routinely recommend. We're not going to treat you right away, but we'll keep a close eye on your PSA. And we expect the disease to be very slow growing. Maybe you have, other, competing medical problems, and it really avoids the side effects of radiation and surgery. So this makes sense for a good proportion of men. You can still get treatment down the road if things progress, but there can be a lot of anxiety. What's my PSA? What's my PSA doing? And sometimes that can be, very anxiety provoking. Can it spread? Yes, but usually you're plugged into the system, and we would catch it in time to treat it. The patients with an intermediate risk prostate cancer, we're going to discuss, is it surgery or radiation based on your risk tolerance? What is important to you, quality of life, et cetera? Are you a candidate for surgery, or would radiation be a better option? There's different types of radiation. There's the standard sort of external beam, intensity modulated radiotherapy. And like Charles said, this was like an 8 to 9 week course, 44 sessions, Monday to Friday. Seeds are little radioactive seeds that are put into the prostate. And then more and more centers are adopting the CyberKnife. How do we minimize the number of times that you have to go to radiation? Can you do higher focus radiation in a shorter amount of time? Unfortunately, the studies have shown that patients that have radiation plus hormonal therapy do better than radiation alone. So a lot of men are getting androgen deprivation therapy. So we have to cut off the testosterone for a period of 6 months to 2 years, because that makes the cancer cells a little bit more sensitive to the radiation. And we heard that, there are side effects, unfortunately, of androgen deprivation therapy. If you're going to get radiation, I think that all men should probably ask about this kind of gel that goes in between the prostate and rectum, and it really eliminates any kind of radiation damage to the rectum. It's called Spacor. Another one is called Barrigel, and this does require an added procedure, sometimes in the office before radiation, but this is sort of the evolving standard of care, and I would sort of ask your treating radiation oncologist am I a candidate for space work? There are side effects, unfortunately, of radiation. I would say that they do affect erections, but probably in a longer time period rather than surgery. We call prostatectomy when we remove the prostate gland and we make the connection between the bladder and the urethra. I think this is great for young men who want to get the cancer out. We get a lot of information from the prostate itself, and it really allows us to kind of predict the future based on the disease that you have. You take the prostate out, the PSA goes to undetectable. As long as it stays undetectable, you are cured. And we recognize that men want to get back to their life. And so, historically, I think, we did this open surgery. Nowadays, we can do it in a robotic, minimally invasive fashion, get guys back to their life very quickly. This is an overnight stay in the hospital, catheter for about 7 to 10 days. And it's really, speed up continence, for men. And nowadays we can kind of try to preserve the nerves for erections. And so, the trifecta is no cancer, you're fully continent, meaning you're not having to wear pads, and, you are getting erections. There are other treatments out there for prostate cancer. This is not for everybody. This is high intensity focused ultrasound. This is maybe if you have a small, small amount of disease in like one of the prostate lobes, and you just want to treat certain areas. So some centers are doing this. I think that probably the same candidates that are for active surveillance are probably good candidates for what we call a high intensity focused ultrasound, or HIFU, but you may hear a little bit more of that down the road. If you have prostate cancer, how do you, stay healthy? I think stop smoking, take a low dose statin, supplement your vitamin D, and, metformin has been one of these kind of wonder drugs for multiple different reasons. So talk with your primary care doctors about how do you do that, staying healthy. So I would say that prostate cancer is common, and the aggressiveness is quite variable. Earlier detection is favorable, so get your PSA checked, whatever it takes to kind of get the blood test. We want to maximize detection of intermediate high-grade cancers, so no longer are we treating the low-grade non-life-threatening cancers. Imaging, molecular biomarkers are used to improve risk stratification, especially in the gray zone. And then this has allowed patients and urologists to be a little bit more comfortable with active surveillance. So very low risk disease, I would say active surveillance, surgery or radiation for intermediate high risk disease. And then other treatments are becoming a little bit more common. And we really want to minimize the side effects. So thank you so much for your attention, and happy to answer any questions you may have, but fantastic format.
It's an extraordinary presentation, and I don't even know, excuse me, where to begin with questions. But is there anyone out there that has any questions for the doctor? It's very quiet. No one?
Oh, it was so much good stuff at one time.
Yes, indeed. George, did you have a question?
No. I just.
All right. Well, Doctor, I just want to ask you a quick. One of the things that we struggle with when we hear these sort of presentations, they are very, very clinical. So let me just ask you, you started off the conversation and you mentioned, I think, metastatic twice. I believe metastatic is the spread of the cancer to other organs. Is that true?
Correct. Yeah. Prostate cancer typically goes to the lymph nodes, the bones, and it can go to other areas, but those are the primary targets when it comes out of the prostate, metastatic disease. So it's either localized to the prostate or metastatic.
And tell us a little bit again, what is a biomarker?
A biomarker. I would say that it can be blood, it can be urine, and we recognize that like prostate cancer, has certain, aggressive genes that are turned on. And so if, within your tissue or your cells, we can find those particular genes, we can say, okay, Tony's prostate cancer is secreting, X. If we can find X in your tissue or blood, then we can say, okay, well, Tony may have a more aggressive prostate cancer. You're someone that we need to biopsy. But if we look for, X and we don't find any, maybe you're okay, not to biopsy. And so, these are markers that have been found in sometimes low-grade cancers, sometimes more aggressive prostate cancers. So like little breadcrumbs that we, use to kind of help, put you in a category, are you someone that we need to be more concerned about or not? And, there's a lot of men, that are very, fearful, hesitant about the biopsy. I find that, this is the perfect patient, to either, make them feel more comfortable with this decision or make us, feel more comfortable, maybe just observing and not doing a biopsy.
Thank you for that. So you mentioned fear and hesitation. Yeah. When you look at this guy here and you talk a little bit about the digital exam.
He looks unhappy.
Yes. Dr. Stern, I've talked about this over the last couple of years. There are still facilities that are saying, doctors that are saying, digital exams are out based upon the white papers. I'm hearing from you, as I've heard from Dr. Stern, that just simply is not true. What do you say to us to communicate to your colleagues that digital, even though this guy clearly looks uncomfortable, the digital exams are still required?
Perfect. I guess, I'm old school. I still like to make phone calls. My wife's like, no one calls anymore. And I went to Howard University and there was this one surgeon, LaSalle Lafall Jr., and he was 80 years old, first Black president of the American College of Surgeons, just a fantastic educator, clinician, researcher. And, he came into the room, you stop what you did and you listen to him. And, he said, the only reason not to do a digital rectal exam is if you don't have a finger. And every time I'm in a room, with somebody, a patient, I feel guilty not offering a rectal exam. A perfect example, I saw, a young guy, he's 55 years old, comes to me, unrelated reason, check his PSA, it's normal, completely normal, not someone that I would pursue. I did a rectal exam on him and he's got an abnormal prostate on one side. I said, you need a biopsy. We biopsied him. Now he's got high-grade disease. Had I not done the biopsy, he would have been walking around. It possibly could have gone metastatic. So there are some situations where the PSA is normal. It's so aggressive that you don't secrete a lot of PSA. And, you may miss it with just the PSA testing alone. So, it's an anecdote, but every so often, a couple times a year, patient like that will walk in. So I feel like I owe it to my patients, right, to do it. And it's uncomfortable, but it's about 10 seconds. We just taught the Harvard medical students how to do the digital rectal exam on these models. They pay $70,000 a year, and there's some physicians that they practice with and that don't let them do the rectal exam. I told them, you're paying enough that, you need to get practice to do the digital rectal exam. It's nothing to be ashamed of. And I think it gives us a lot of information.
I know that we've talked a lot about symptoms, and, I look at, again, this gentleman here in this picture. Again, the question that folks keep asking, what I hear, there are no symptoms, or are there symptoms that tell you that you have prostate cancer or something's going wrong?
No. If you have symptoms from prostate cancer, it's spread. You're having local problems. That's almost too late. So that's why we screen, because you're not going to have symptoms. It's the same thing with colonoscopies. People don't go and get a colonoscopy because now they have, profuse bleeding from the rectum. They go because it's, they're 40 and 45 and they just know that I got to look because I'm not waiting for symptoms. If you wait for symptoms, it's too late.
Thank you for that.
Tony, can I please comment?
Oh, yes. I was about to introduce you anyway.
Thank you so much. It is, as Dr. Basin pointed out, it is a minority of patients where digital rectal exam would be abnormal, while PSA will be normal. It's about 10% of men. But still, we do not want to lose a possibility of early detection of prostate cancer in 10% of men because we are avoiding digital rectal exam. But what else is very important to remember is in 90% of men, it is PSA blood test that makes it possible to make diagnosis.
Very well.
But so the probability right now with the current state of the art is current recommendation, it is less likely for primary care physician to do digital rectal exam. But if there are clinical concerns and men come to an expert, I don't think any expert would want to miss 10% of men with prostate cancer.
Thank you. Thank you. I'm going to, first of all, again, Doctor, thank you for your presentation. It was awesome. I know now what a biomarker is, and I still know that it is important to get that digital exam. And so we thank you for that. Your presentation hit everything right where it needed to be hit. Right now, I'm going to introduce Dr. Faye Stern, the president and CEO of AdMeTech. No secret that Dr. Stern believes strongly in equity, but believing strongly in equity is one thing. Leading equity is another. So we welcome Dr. Stern and the work that you're doing. Please give us your presentation.
Thank you so much. First of all, Tony, Steve, Phyllis, Janet of Brockton NAACP, thank you for this opportunity. I want to thank my staff, Thomas Satam, Emma Coyer, Trisha Kinney, Erin Roberts recently joined us. I want to thank all of you for being here today, and all of you made this event possible. Tony, I am a very much results-oriented person, okay? And I like seeing results as soon as possible, definitely in my lifetime, right? And I cannot even begin to tell you how much I appreciate partnership of Brockton and NAACP. Since 2015, when I brought to their attention that Brockton and Plymouth County led the state in Black mortality in prostate cancer. And since that time, Steve Bernard and his colleagues in Boston AC, particularly Phyllis, Janet, Leona Martin, they led the charge in making sure that community in Brockton and surrounding areas has been mobilized from mayor to city council to print media to digital media to interviews with you in Brockton, at Brockton on television, just to make sure that there would be very sharply increased awareness of the importance of early detection of prostate cancer. And it is because of this incredible broad community engagement that together, within literally several years, we managed to reduce prostate cancer mortality by more than half in Black men and by about 30% in white men. This started when Black men were dying at a rate of 2.7 times higher in Plymouth County compared to white men. Right now, Black men are dying at the rate of 1.2 times higher than white men. We are very close to parity. We are not there yet, but I believe with prostate cancer equity program that I will describe in a couple of minutes, we will get there in a few years. And Brockton and Plymouth County will be a model, not only for the state, but for the nation. At this point, Emma, do you mind to please demonstrate my video? My name is Faye Stern. I'm a physician and president of the AdMeTech AdMeTech Foundation, a nonprofit organization providing leadership for groundbreaking programs in prostate cancer at the global, national, and state levels. Our programs have been transforming the quality of patient care and reducing health disparities. Dr. Sean Vason described recent advances in prostate cancer screening, diagnosis, and treatment. The focus of my talk is on our prostate cancer equity program, launched recently to bring these advances in patient care to every man in Massachusetts and eliminate health disparities. Prostate cancer equity program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. I'd like to express my gratitude to the members of the Brockton delegation to the State House who made this program possible, including Senator Michael Brady and Representative Jerry Cassidy, Michelle Dubois, and Rita Mendez. For public awareness and education, our messaging centered on the importance of screening and early detection, critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are about 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. The latest 6th annual conference took place in September last year. Our summit has been recognized as a seminal event in shaping the state of the art and future vision for prostate cancer care. Our summit brings together the key international experts representing every clinical expertise involved in patient care to review the best emerging clinical practices. Summit 2022 showed rapid advances in patient care. In screening, our summit supports clinical practice guidelines recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. High-risk men, including individuals with Black heritage and with family history of prostate cancer, are recommended to start screening with PSA blood test at the age of 40. Average risk men should start screening at the age of 45. This first, or what we call baseline screening test in younger men, has emerged as one of the most important indicators for identifying men at risk of lethal prostate cancer long-term over more than 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. This non-invasive diagnostics highlighted the importance of PSA screening and shifted past concerns about screening into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsies and treatment, and optimize selection of personalized care for each man, including careful observation, what we call active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, compared to white men, Black men are less likely to have precision diagnostics such as advanced imaging, MRI or molecular imaging, molecular or genetic testing, and to undergo life-saving treatment. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any non-invasive testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and NAACP New England Area Conference, with their multiple branches located across the state. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion in person or virtual visits. Any Massachusetts man age 40 and older can take part. Our priority focus is on Black, Hispanic, and Latino men who are at high risk of prostate cancer, delayed diagnosis, poor quality care, and death. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of prostate cancer to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in this program take care of our families and friends. This process consists of 3 components. First, AdMeTech Foundation Administrative Coordinator collects basic information and matches individual patients' needs with the experienced nurse for patient education and the appropriate state's experts for clinical care. Second, a clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit and related needs, including registration into healthcare system, transportation, and financial assistance if needed. Third, if an expert recommends any next steps, AdMeTech's coordinator, educator, and patient navigator work with patients on the appropriate follow-up, such as, for example, testing or treatment. Trisha Keeney, a member of the AdMeTech Foundation staff, serves as a statewide coordinator and the initial contact for the Prostate Cancer Equity Program. Our community partner, Latino Health Insurance Program, helps men to obtain health insurance, such as Mass Health, if needed. If you have any questions or need assistance, please contact Tricia by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention. At this point, I would like to ask George Brickhouse, who was one of our first patients in Prostate Cancer Equity Program, to share with everyone what it was like for him to deal with healthcare systems before and after he came to Prostate Cancer Equity Program.
I'm really blessed to be able to participate in the program. Steve Bernard took me in one day and said, why don't you get involved with this Zoom call and see if it's anything that you might want to be part of or to benefit from. After the Zoom, Dr. Stern made a personal call to reach out to me because I had concerns about the original doctor that I'd been to see. Just kind of wanted to, why don't we move on really quick? Why don't we move into this? And why don't we go into this? And going into this kind of frightened me because it's me that he wanted to go into. So I said, the PSA was a little bit over 6. And I said, I'd like to back off for a month or two and maybe go into some herbal remedies. And it was interesting to hear Erin make reference to the fact that she had pulled her dad into some of the herbal supplements that she was dealing with. Is exciting. A question, and I'll get it back to me, that Tony made to Darren was intriguing in terms of how do we get the message out? How do we get people, young men of color, to say, let me be concerned about me beyond the point that I might have knowledge of? And it jumped out at me today because today I met with the principal and the South principal of the South Middle School in Brockton with a program that I will be starting in 2 weeks called CAT, Critical Analytical Thinking. And if you take a look at what the COVID has done to our people on an overall basis, mental health, it doesn't matter what age you are, everybody was affected in some way or another, and especially our youngsters. But that made me think of, if we're really looking, I believe we need to get into the high schools with the message from AdMeTech to take home to their parents, because high school is normally their parents are going to be in that age range from maybe 35 to 45. They're going to be working maybe 1 or 2 jobs, maybe. Single parent home, maybe. We have a lot of maybes going on. But if we can narrow it down to get people to think, because right now there's a lot that's on everybody's plate. And as I said, the purpose of the program, CAT, that I'm initiating was because we need to take a closer look at where our youngsters are in grade school. And Tony's question to Darren made me say, look, if we can do this there to help educate and enhance thinking, the thinking process, we need to get people to think about their health. And Dr. Stern did that for me. She said, hey, look, let's take a look at what your guy is proposing, and let's take a look at what we're proposing. And there was the level of care. There was a genuine concern of, we can bring a team to you to take a look. If you don't like it, fine. But if you do, we can help you. And Dr. Tren, that is my guy, is on point in terms of, hey, look, we're going to do this. And then in 6 months, we're going to take another look to see where things are at. And during that time period, I've gone back on my supplemental health, herbal substances, and I'm quite excited, to be truthful with you, to see what we're going to be and where it's going to be probably in about another month. We're almost at that 6-month mark. And I just believe that if we can reach out on a wider scale, I think that we can get youngsters to maybe go home and ask a question, or maybe if they have literature to take home, that the parents can read it and say, maybe, you know, this is something I might really need to take a look at, because I don't want to leave my family in a situation where I'm not there to help them. And I feel being part of the AdMeTech family, and that's what I regard all of you as who are here this evening as family, because you care enough to be here and you care enough to allow me to take this time to share with you where I'm at and what I'm doing. And it's exciting. And I'm looking forward to the future when we can all have the help brought to us that we are all entitled to have by the grace of God. I appreciate your time. God bless you all.
Thank you so much, George. Tricia, you are our Prostate Cancer Equity Coordinator. You are the first person men usually see. Do you want to share why you're so passionate about Prostate Cancer Equity Program? Anything else you would like to share?
Yeah, absolutely. So hello, everyone. Thank you so much for joining this event today. So as Dr. Stern mentioned, I am the coordinator of the PCE program, the Prostate Cancer Equity Program. So essentially, I would be your first point of contact if you contacted AdMeTech regarding this program. So I work closely with the healthcare system's patient navigator to ensure that each individual's process of finding a provider or seeking support resources and securing health insurance is seamless. And that is exactly what this program strives to do. As Dr. Stern said, support patients during every step of their medical journey. So whether you are looking for a second opinion or screening, please do feel free to contact me. I would be happy to answer questions you may have about the program or help you find the resources you need. So I will put all of the contact information in the chat box again, so that's available to you. Thank you.
Thank you so much, Tricia. And
Hello? Can I speak?
Absolutely.
Hello?
Absolutely.
Yes. First of all, I just want to say, you know, I'm absolutely amazed by the amount of information and the complexity of the information that's being presented. I'm a therapist. I've been in the field for 50 years. And what concerns me so much is that this is great information. And I like what the gentleman before was saying about let's get our young men involved in this. I mean, they need to know that, you know, as a teenage girl, I knew about GYN exams and ovarian cancer and this and that. People began to teach me. We need to teach our young men. And I like what the gentleman was saying. Let's get the schools involved so that these young men know what might be happening down the road. Thank you.
Thank you so much. Thank you. Our call to action today is we are proud of our Prostate Cancer Equity Program. We are proud of working with physicians like Dr. Sean Wason or Dr. Trink at Harvard Medical School or Dr. Mitchell Sokolov at UMass. We selected the best experts in Massachusetts to serve men and to address disparities, people who are passionate about addressing health disparities in Massachusetts. And we strongly believe that our program is a fundamental solution to men not ever struggling alone again with any kind of problems with medical establishments. And our call to action today is to please contact Tricia. Every man, every woman who has men who she cares about, every young man or young woman who have parents 40 years and older, please do not hesitate to call Tricia, and we promise to take great care of you.
Dr. Stern, thank you for that. It looks like we are nearing the hour. So I want to first say thank you to the community for showing up for this virtual event to talk about prostate cancer awareness, to talk about the new technology, to talk about how we can even speak to our physicians about that, digital thing. But nonetheless, you guys have been great this evening. You all have been great this evening. Get tested, ask questions. And I love what Steve has sent out. It says, I lost my father. My son should not lose his. So, keep on top of this and stay tuned. Love what Brother Brickhouse has said about getting into the schools. I think that is really, really an important option. Dr. Stern, thank you. We salute you and we hug you. Dr. Wason, we salute you and we hug you. Thank you to President Ellis of the Brockton Area Branch NAACP and all of those that gave testimony this evening. This has been the NAACP Forum with AdMeTech talking about prostate cancer awareness. Have a great evening.
Thank you. It was wonderful. Wonderful.
Thank you so much.
Yep, thank you.
Thank you all.
Good evening.